Good morning. Thank you very much for inviting me here to speak. I am a neuroradiologist, and so my background is quite a bit different than most of yours, and I'm also, I'll be happy to answer questions at the end or even along the way. If something is confusing or you have a question, please go ahead and interrupt. I know it's very early in the morning for most of us, and that might keep us awake a little bit better. I do have disclosures. Probably most importantly is I do have research support from Ad Radiopharmaceuticals, which is owned by Eli Lilly, and I participate in clinical trials from several pharmaceutical companies. So the overall goals of the session this morning, I thought we might start by reviewing that. And these are to understand new imaging methods in neurodegenerative diseases, biomarker signatures for neurodegenerative diseases, and in particular focus on Alzheimer's disease, how biomarkers can be used in conjunction with clinical findings for differential diagnosis, use of biomarkers in targeted therapies, and barriers for use of amyloid imaging in clinical settings. And in particular, I'm going to be the first talk in this series, and I'm really going to focus on some of our foundations of where we are with imaging biomarkers, particularly in Alzheimer's disease, how we've come to this point, and what we might be looking at in the future. And so we're going to focus on what are the currently available clinical tools for dementia imaging. What's this concept of preclinical imaging? So preclinical Alzheimer's disease and imaging in that phase where people are pre-symptomatic or very early symptoms. How we can use imaging, both MRI and PET, and combined with clinical findings to really refine a differential diagnosis. What are the barriers for being able to use those tools? I know most of us in our clinical practices don't use these tools right now, and why is that, and what might be changing in the future, as well as to try to think about how these might fit into a future where we have drugs available for Alzheimer's disease and how we can use these tools to really put together what drug might be correct for the right patient. So a lot of this is going to be thinking forward to what your practice might look like in 5 years, and how can we build that foundation right now to be ready for it. So I think we're all pretty familiar with what happens to the brain in neurodegenerative diseases, and in particular this is a case of a patient who expired with Alzheimer's disease. But frankly, at the end stage of many neurodegenerative diseases, we have very similar findings of this widespread atrophy. Oh, wrong button. Okay. So you can see enlargement of the lateral ventricle in these coronal slices. Here we can see enlargement of the temporal horn and the hippocampal atrophy. And even if you look along the surface of the brain, these areas where we can see the widening of the sulci. So all of these are findings that are apparent on structural brain imaging and that we can have correlates to. We've had this for a long time, but I can tell you as a neuroradiologist, what the information we give you from a scan like this is pretty limited. We tell you there's advanced neurodegeneration, and you already knew that from your clinical exam. So what's changing now? Well, for a long, long time, neuropathologists have been able to examine the molecular pathology of Alzheimer's disease post-mortem, and that's the pathology of the amyloid plaques, which are comprised of beta amyloid peptide aggregates, as well as the neurofibrillary tangles, which contain hyperphosphorylated tau. And in particular, these can be stained. In this case, this is a silver impregnated stain. But what they are also able to stain them with are a class of compounds known as thioflavins, which result in fluorescence of the plaques and of the tangles. And it's really based upon the structure of these thioflavins that a whole class of imaging compounds has come together, which allow us to do in vivo molecular imaging of the Alzheimer plaque pathology. So the first studies started almost 15 years ago, really. And the first compound was Pittsburgh compound B, or PIB. And what I'm showing you here are axial images through the brain of a negative scan. So what you see on a negative scan is really just the white matter uptake. as well as a positive scan, where now you still have the white matter uptake, but it's really overshadowed by that cortical uptake. Or the other way to think about it is you can no longer separate that gray and white matter in your mind. They're blurring together. And since that compound, more recently, a whole class of compounds have been developed, which are now commercially available and have FDA approvals in order to be able to do clinical scanning for these compounds. And the first one available was florbetapir from Eli Lilly. And you can see very similar findings with that positive scan on the right, negative scan on the left. Here's flutometamol scans, florbetapin scans, and Navidea's compound AZD4694. And the major breakthrough with these, for those of you who don't do PET imaging that much, has to do with the half-life of the tracer. So carbon-11 has a 20-minute half-life, and that means we can only do these studies at specialized research centers that have a cyclotron on site. And so the real breakthrough is when we switch to an F-18 compound, then that's much more similar to what we do all the time with, you're probably more familiar with FDG scans for PET. So fluorine has a much longer half-life, and it allows these to be produced in one city and then transported to another city. And so that's what's really made these now available for clinical practices to start to employ. In using studies with Pittsburgh Compound B predominantly, we've really come to understand a new model of what Alzheimer's disease represents. This is not a disease that begins when somebody has symptoms, when they have memory complaints. This is a disease that probably begins 15 or 20 years before those symptoms begin. And so this is a curve showing what we expect to see both for an amyloid PET as well as changes that might happen with a CSF A-beta test. And so that CSF would be going down. And so that scan becomes positive long before they have symptoms. The second stage that we think about with this is a neuronal injury stage. And that can be examined with multiple different tests. So if you use CSF, you can start to look for tau and p-tau in the CSF. If you're doing an MRI scan, you can start to look for early signs of atrophy. If you're doing an FDG scan, you can look for loss of metabolism, so we call them hypometabolic areas. And then more recently, this is an AB1451 scan, we're starting to look at tau uptake in the brain. So the second molecular pathology is now something that we are starting to do in research studies, and that allows us really to start to develop a foundation of what are the preclinical stages of Alzheimer's disease. And of course, the very last thing that happens is that cognitive change. And that's what we would all like to try to prevent in the future going forward. So how did we get to this point? I thought it might be helpful to review just a couple of the early studies that led to this. And so this was a study that came out of Chris Rowe's group in Australia. This was back in 2007. And this is a nice illustration of the spectrum of findings that we can see. This is using Pittsburgh Compound B. And on the far right, you can see a typical scan pattern in someone with Alzheimer's dementia. So you can see there's uptake in the frontal lobes, there's uptake in this area of the medial parietal lobe called the precuneus. But you can see that in MCI, we have a very similar pattern. And even in healthy controls, we have the start of that pattern, that development of this concept of preclinical. There's another really important thing to point out on this slide, and that is that not everyone with MCI, mild cognitive impairment, has a positive amyloid scan. And in fact, more recently we've learned that not even everyone with a clinical suspicion for Alzheimer's disease necessarily has an amyloid in their brain when we do scanning. And we think that there's, probably some people think, well, maybe the scan is incorrect, but more likely the evidence is suggesting that probably our diagnoses need some refinement, and some of these tools might be able to help us do that for our patients. And then this is showing you from the same paper the quantitative scores for those studies. And this is what's really important, is there are in fact overlaps between the normal and the MCI group, and between the MCI group and the AD group, and that's this spectrum of the amyloid deposition and what we can measure with our molecular imaging. We've also learned not only do people get these plaques, but once they start to accumulate amyloid, they accumulate it relatively rapidly over time, at least in an early phase of the disease. So this is a study of about 200 individuals who underwent a PIB PET scan. They were all actually cognitively normal at their first imaging test. And what you can see is there's a large group of people who stay here in the negative range. Nothing's changing. But there's also a large group of people who are accumulating amyloid, and there appears to be a phase where they're accumulating it relatively steeply. And then a suggestion that in the very oldest stages or later ages, there might not be as much accumulation. We don't know what causes this rapid accumulation, what's going on during that phase, but I think it's an important concept to understand when we think about our clinical patients, because indeed someone that might come in at this time point and have a negative scan could very well be positive if we re-imaged them 5 years later. So just because someone was amyloid negative at your first clinic visit even doesn't necessarily mean 5 years from now they wouldn't necessarily have Alzheimer's disease pathology accumulating. So it's a dynamic disease, and we're thinking about it in stages now. We've also learned quite a bit in recent years from genetic studies of Alzheimer's disease. So this is from the Dominantly Inherited Alzheimer Network. This is a study where we have cases of patients who have a genetic form of Alzheimer's disease. So it's very rare, and they develop it at an early age, but the critical factor is they actually develop this at about the same age that their parents did. So if your parent developed Alzheimer's dementia at age 45, you're likely, if you're a carrier of one of these gene defects, to likely get Alzheimer's disease about that same age. And so that lets us actually stage these people based on how many years they are before they get symptoms. And so if we look at the difference, these are maps of genetic carriers and then their siblings, which are the non-carriers. And at time 0, so this is at the time when we're expecting them to have Alzheimer's dementia, you can see their amyloid PET scan is very widely positive. So lots of deposition of that amyloid plaque, which is what we expect. But we also see now that if we look back 10 years before they have symptoms, their amyloid plaque is already present as a positive scan. And if we go back even further, you can start to see subtle changes if you look in the frontal lobes or you look in that parietal occipital area of that amyloid accumulation. So this really supports this idea that Alzheimer's disease begins many, many years before those symptoms initiate. And in fact, we do have tools that can allow us to make that diagnosis at a very early stage. This next slide is going to look at the same data, and what this is a movie that we've made based on the regression of that cross-sectional data. We're looking at the same slice of the brain that we just saw in the other figure. So this is at the level of, this is an axial image of the brain, the frontal lobe. Here's the parietal occipital, basal ganglia. And we're going to start this about 25 years before we expect to develop symptoms. Okay, so you can see the clock is ticking down below. We're about 20 years out, and you can see that amyloid accumulation growing. We're about 14 years out now. Now we're at that 10-year phase, and you can really see that amyloid accumulation that we're finding 5 years out still. And it's only now that we're entering that symptomatic stage of the disease. And what you start to see in these symptomatic years is, in fact, if you look carefully, not only are the ventricles more well-defined, but they start to grow as well. So we can actually even see some of that brain atrophy on our molecular PET scans, which is quite frightening. But this is the kind of data that's come together to really build support for these models of the concept of preclinical Alzheimer's disease. There's also been a wealth of research going on with structural imaging, and not just what is that signature of the brain when everything is degenerated, but what does the brain look like in the very, very early stages. So this was a study, again, back in 2007, looking at patterns of gray matter atrophy in people who had MCI and differences between those who progress to Alzheimer's disease and those who don't. And you can see there are some specific areas of the brain in the temporal lobe that had a difference. And then perhaps more dramatically is if you look at what their brain atrophy now looks like at the time of that Alzheimer diagnosis, so spreading even more widespread. And there are hundreds, if not thousands, of papers that have been published now really looking at atrophy and signatures of atrophy changes in Alzheimer's disease. And I bring this up because these are difficult changes to see visually, but with quantitative imaging, and we're seeing now tools for quantitative MRI become available for clinical practices, findings like this are not going to be so far out of reach for our patients. And then this is just going back to our autosomal dominant study of the Diane study, just to point out how there's support for this as well. So again, if we look, now these are surface projections of the brain, the medial and the lateral surface. This is that amyloid accumulation that we've already been looking at, going back from time 0 to 5 years before symptoms, 10 years before, 15 years before. But just to point out that there are changes in cortical thickness that are measurable back in that 5-year range. And if we look, I'm not spending a lot of time today talking about FDG. FDG's been around for a long time and is still available, but if we use FDG, you can see there are patterns of hypometabolism on FDG PET that are detectable even back in that 10-year range. So still a valuable tool that is available and actually does get reimbursement if you're in the United States under Medicare. So something to remember that you have available as an option. So where are we currently, and what tools do we have available? So for most places, a workup will begin with a non-contrast head CT. And you know that the role of that is really to determine treatable causes, things that are coming up right away. So this is a patient that has a subdural hematoma. You can see that there's mass effect on that right lateral ventricle. There's a little bit of midline shift. This is obviously a cause of something that we'd like to intervene on and work on. This is a case that probably didn't have a clinical presentation that looked like Alzheimer's disease. This was a patient that came through our ER. But subacute or chronic subdural hematomas are often present in older patients and can have effects that are something we want to look at. Up until now, the role of your brain MRI has also been to look for other causes for this dementia. So, for example, this is a patient who has normal pressure hydrocephalus, and you can see the marked ventriculomegaly out of proportion to the sulcal enlargement on this coronal MRI image of the brain. And then typically we've reserved FDG PET for more complicated cases where we're not sure what type of dementia it is. Perhaps it's Alzheimer's, perhaps it's another disease. So this is a patient who had a form of limbic encephalitis related to autoimmune antibodies. And you can see on his FDG PET scan this hypometabolism bilaterally in the temporal lobes and some corresponding flare hyperintensity on his MRI scan. But, you know, so far none of these have really been a good diagnosis for Alzheimer's disease. And so what are the new options that we have available? Well, there are quantitative tools for MRI available in clinic now. We do have FDA approval for amyloid PET imaging. Many centers now can do combined imaging with PET MRI, where you could combine your FDG PET image with an MRI or your amyloid PET image with an MRI scan. And as well as if your patient has symptoms that are in the Parkinsonian spectrum, you can think about dopaminergic imaging. And so I want to show you this. So this is one of the commercial clinically approved products for FDG PET. I don't have any association with this company, but I wanted to point it out because it is something that's available for people to be able to do quantitative volumetrics in order to compare these things. And then I wanted to talk a little bit about that amyloid PET and what's going on with that. So there, right now, amyloid PET has some appropriate use criteria that have been developed in conjunction between the Alzheimer's Association and the Society for Nuclear Medicine. And these are suggesting that the amyloid PET is appropriate in cases where there's a diagnostic dilemma, such as persistent or progressive mild cognitive impairment that's not quite fitting an Alzheimer pattern. The idea is that these are patients who have been evaluated by a dementia expert. So, you know, you are the neurologists, the dementia experts, and the idea is that you are still confused, not someone who's in general practice who may see geriatric patients just as a small component. And finally, that somehow this diagnosis would alter the management for that patient. And importantly, not appropriate for asymptomatic patients as a screening test. Someone comes in and says, you know, my mother had Alzheimer's disease. Can you see if I have this? As well as not appropriate for medical legal purposes. So a family wants to take away legal privileges from an older relative. They want to claim that they're incompetent. So this is not an appropriate use for amyloid PET imaging. But even with that, Medicare is not paying for it right now as a whole. The only way that you can really reliably get these scans, and Gil will be hopefully talking about this a little bit later because this is his study, is part of the IDEAS study. And this is actually a research project that will allow over 18,000 Medicare beneficiaries to get amyloid imaging. And it's really looking at two things. First is how this might alter the short-term management of the patients, as well as whether long-term this will alter their Medicare claims. So the idea is that perhaps if you knew someone had Alzheimer's disease and they were having cognitive changes, you wouldn't necessarily send them directly to the ER. You might know that this was a treatment, they needed management of their Alzheimer's in some way. Okay. And so what I wanted to do in the last bit was really come back and focus just on an individual patient. And so this is a research participant, but we could imagine this being one of our clinical patients. She first presented to our memory clinic when she was 64 years old. And at that time, she thought she had some memory complaints, so subjective complaints. She said, I'm having word finding difficulties. A couple of years later, she enrolled in our imaging component of the scan, and you can see, you know, her brain is not entirely normal, so these ventricles and sulci are a little bit larger than what we'd see in a 35-year-old. She's got some flare hyperintensities, periventricular. We don't see anything that looks like an infarct. We do see that the hippocampi are small, those temporal horns are large. But frankly, for a clinical neuroradiology read, that's about all we could say. So could this be an early Alzheimer's scan? Sure. Could it be a normal scan? Potentially. It's a very difficult thing. So this is what we're doing in our clinical practice and in our research studies. We have our own version of the quantitative MRI that we're doing. And so what I'm showing you here is the mean of a normal cohort group across the age spectrum. The normal cohorts for this came from our research study, and these were about 150 participants who were cognitively normal for 3 subsequent years and also had biomarkers that were negative for Alzheimer's disease. So a clean normal cohort. And the dark band is 1 standard deviation. The dotted line is the 2nd standard deviation. And this arrow is showing when she was having some memory complaints. And our imaging starts a little bit later, and you can see the right hippocampal volume is at the 10th percentile when we got our first scan. She was still, at that point, she had a normal mini-mental status exam. It was a score of 30, and her clinical dementia rating, or CDR, was 0. When she came in just a couple of years later, now the hippocampal volume's at the 3rd percentile. Her mini-mental status was still 29, but clinically she was diagnosed as a CDR 0.5 based on some changes in her household living. She was having difficulty cooking, organizing meals, things that she had done for a long time. And she continued to decline until she was a CDR 1 at her last visit. But you can see how powerful a tool quantitative MRI can be in terms of how we can now quantify that not only is this abnormal, but it's actually changing, and it's changing in a way that's different than the normal aging that we see. She does also have a This is a Florbetapir scan, her PET scan, and you can see we can't see the difference between the gray matter and the white matter. So this is a positive amyloid PET scan, and that's also helpful in the setting of someone when there's a diagnostic dilemma, because there can be many causes for hippocampal atrophy. So we've all seen hippocampal sclerosis, we've seen cases of infarcts, we've seen cases where people had a history of trauma. And so this is kind of the second component to help us know that this is really an Alzheimer type neurodegenerative process. And then she also has CSF staging, where her CSF beta 42 is low. So for this assay, 400 would be normal, and her CSF tau and p-tau are very high. So these would be maybe in the teens to be normal. So really has all the testing that helps us come together with an Alzheimer's diagnosis. And then looking ahead to the future, the next component of how we could be staging this is going to be using tau PET scans. And this is a scan with AV1451. Gil will be talking in more detail about tau PET and how it can be integrated, but I just wanted to show you for this patient. These are coronal images through the brain. You can see the temporal lobe uptake, and as we come posteriorly, you can see she's got it in the parietal and occipital lobe. So this is the concept of, there's this Brock staging for tauopathy, where early on it's really only in the transentorhinal cortex, then it spreads into limbic areas until finally it's in isocortical areas. And I can just play this movie for you as well, hopefully. So this is going through, we're going to scan through her brain in coronal images. Because you can really appreciate that spreading the connected temporal lobe uptake, and how it's, even the stuff in the back is all connected and spreading posteriorly. So really multiple lines of imaging tests coming together to support this idea of various staging of preclinical Alzheimer's disease into clinical Alzheimer's disease, and the idea that we'll be able potentially to develop targeted therapies for each of these stages in the future. So while a lot of this is out of our reach right now in clinical practice, I think it's going to be with us very, very soon. So we really can use current FDA-approved imaging. So there are, as I said, there are approved tools for the quantitative MRI, such as that NeuroQuant. There are approved amyloid PET imaging, which really, when you combine that with your clinical exam, can give you not only a diagnosis, but perhaps a staging as well. In my experience, the greatest challenge is reimbursement, and we spend a lot of time talking about reimbursement for the amyloid PET scans. So, you know, that no one will pay for it, so we can't get it for our patients. It is also a challenge for the quantitative scans. So the reason a lot of people aren't adopting these commercially available tools are because there's no reimbursement in a lot of practices for that. And so some groups like ours are just developing our own in-house tools. But then I think the other component that we forget a lot is that we really have a shortage of these memory experts in clinics. So as a neuroradiologist, what I see are a lot of referrals for workups for patients with memory complaints and dementia, and they're getting an MRI because they can't have direct access to a memory expert. You know, the waiting list in the memory clinic may be months long. And so I think that's an important shortage for us to remember as well as we're trying to think about this. Clinical trials in progress. You know, if you want to get amyloid PET scans for your patients, I really recommend you look into the IDEAS studies. That's a major breakthrough and opportunity for all of us over the next year. And at this meeting, I encourage you to attend. I know there are many, many presentations talking about clinical trials targeting at pre-symptomatic phases, such as the A4 study, for example. And these are going to be the trials that are going to define what our practices look like in the next few years. One quiz question. It's not hooked into your audience response, but you can sort of think about it out loud. So amyloid PET imaging would be currently recommended for which scenario? And it's kind of a trick question because it's phrased as reimbursement, and I'll just admit reimbursement really is not there. But perhaps we can think about it in terms of recommended. So a 65-year-old woman losing her way driving worried that she might need to move to senior living. So just shake your heads, yes or no. Does that sound appropriate? Yeah. And again, it would be, you know, if for you as a neurologist, the diagnosis was still uncertain based on that. Second one, a 74-year-old man, he had history of HIV and is healthy with that, so not having HIV-related infections, leaves his car running in the garage 3 different times over the last year. So the question is this HIV or is he starting to develop Alzheimer's disease? I see some heads shaking yes. This would be a good case scenario that would be appropriate for it. But the last one is 90-year-old woman. She doesn't have any memory complaints, but her family thinks she needs to move to a nursing home. Anybody? Yeah, so everyone's shaking their head no. So good, you get your CME credit. All right. And finally, I just want to thank all of the research participants, both at our center as well as really around the world, who have contributed to these thousands and thousands of studies that have built us to this understanding of how the biomarkers work. Thanks very much for your attention.